Okay, Marcus, if you'd like to start the presentation.
Hello, everybody, and welcome to the IFFS ISA webinar series on andrology. I'm happy to introduce and welcome my co-chairs from ISA, Giovanni Corona and Xila Kraus. And this is the fourth of 6 webinars. The next slide, please. And as you all know, there will be a certificate provided, and is free to watch on the IFFS website when we archive all these presentations. So next slide. Next webinar is February 11, the 5th of 6. Next slide, please. So it's my pleasure to introduce Antti, a friend and a colleague from IFFS. Antti is a medical director of the Avumia clinics in Finland. Please, Antti, welcome and happy to hear you.
I hope you can see my my presentation now.
Yes, we just need to go into presentation mode.
This okay?
Perfect.
Okay, thanks for the kind invitation and introduction, Marcos. Want to thank the IFFS and ISA for this nice opportunity to present this webinar presentation. It's an honor and a privilege with such a distinguished number of speakers in this series. I don't really have any disclosures for this presentation, and I think we're a little bit short of time, so I'll just get going with my topic. So I will be discussing the advanced paternal age and how that affects the offspring health. This is the content that I'm hoping to go through. There's more proof on some of the topics, and some of them the proof is far less, but I will try and make this obvious as I go through the topic. The paternal age obviously has a lot of effects on the reproductive system. I'm not going to go through all of this, but I think it's important to shortly describe the changes that take place, not only with the hormonal system, as you can see that the testosterone levels go down, and obviously the gonadotropin levels go up. But more importantly, I think for the topic, the changes that we see in the semen parameters, which is have more or less all of the parameters, and consequently also, as you can see, the DNA fragmentation of sperm is increased largely as a consequence of the increased oxidative stress. Now, the perinatal risks are quite obvious. I have referenced here Haas paper from JAMA, which shows us that the pregnancy loss among pregnancies where the father is above 50 years is more than doubled. The risk of preterm birth in the same age group, slightly significant, 1.16. And in a similar range of risk, you also see the low birth weight. Another study looking at a little bit younger men, the fathers being over 40, compared to men of 25 to 29, you see a 60% increase in the miscarriage risk. Now, in the bottom, I have also pulled out the data from a Scandinavian meta-analysis done a few years back, where the preterm birth risk is very slightly elevated. The low birth weight doesn't really look as it's significant, and the same holds true for the low for the stillbirths, which is the last number. The stillbirth SB has switched place a little on my slide. Sorry about that. If we then think, before I go through a long list of things, I think it's important to look at the mechanisms, or what do we know about the mechanisms. if we think of the next generation, there's approximately 60 de novo mutations that take place in each newborn child. You can say that the range is between 30 and 90. The number of de novo mutation increases monotonically with paternal age. So we can estimate that there's a 1.35 mutations or an additional 1.35 mutations each year for the paternal aging. Now, through paternally derived allele analysis, it's clear that these de novo mutations, or most of them, 80%, are paternal. And if we go and look at the background of this, at least it's quite obvious that we know from the sperm production that if we compare a man of 25 years old, the spermatogenic stem cells have only gone through 350 replications, whereas the number is 750 for a man who's 45. So the monogenic developmental disorders, which in general have an incidence about 1 to 300, if we look at these different age groups, in the young men, less than 20 years, the incidence is 1 to about 450, and it increases when you go into an older couple of 45 to 1 in every 217. Now, it's tempting to suggest that this mechanism is behind all the detrimental reproductive consequences. However, it's quite obvious that there are other mechanisms in play, and I'll try to allude them as I go through some of the next slides. Now, the selfish selection and the paternal aging effect disorders are a group of diseases where a developmental disorder, which is very specific to these de novo mutations, is associated with a small subset of Mendelian disorders. Now, it's clear that not the de novo mutations as such can explain the high incidence that we see in these. So we also get an understanding of the homeostatic regulation of the spermatogenic stem cells, spermatogenesis, and de novo mutations and the disease incidence. So it's typical that the fathers are unaffected by the disease, and it seems like these mutations, the consequence is a dominant gain of function property, and they all seem to fall within the receptor tyrosine kinase signaling pathway. Now, it appears that due to these mutations, there's a competitive advantage in the spermatogenic development, and therefore a clonal expansion, and consequently the number of sperm with this mutation is increasing the number that they actually end up fertilizing the egg. Due to this, there may also be a rare benign testicular tumor, although these are not very common. So these are the most common paternal age associated disorders. It's important to understand that these are very rare, perhaps except with the exception of the Noonan syndrome, which actually has multiple genetic backgrounds, or multiple genetic mutations are known to be behind that. And this is maybe best shown in this slide, which is a more complete list of these paternal age effect genes and the consequent diseases. I will not go through these due to the time limitation, but in this slide, or the picture, you can see on the picture A, where a selfish mutation takes place in the early stages of spermatogenesis, and this causes the clonal expansion, and then due to the high number of these selfishly selected sperm, the likelihood of them fertilizing the egg becomes fairly high. So in In reality, rather than just having the de novo mutation, the selfish spermatogonial selection leads to a tenfold increase in the incidence of these otherwise very rare diseases. So moving on then to the birth defects, there's several big studies looking into this. The first one I'm referring to had 77,000 birth defects overall. And if we look at the cases where the father was above the age of 40, the odds ratio is just above 1, being 1. I've lost the number, but it's just, you can see from it's just beyond 1. And those included were heart defects, musculoskeletal anomalies, chromosomal abnormalities. I think it's important to also understand that it's not only the older fathers, but also an increase can be seen in the young fathers as in below the age of 25 years. And you can see that the omphalocele and musculoskeletal abnormalities exist there as well. Now, in a Norwegian study with a total number of participants or subjects of the risk for central nervous system anomalies was 2 and 2.5. And then if we look at one of the later meta-analysis by Fang, we see that these risks, although they appear to be statistically significant, the increase that we see in most of these is just barely above 1. So moving on then to the psychiatric problems that have been associated with aging fatherhood. A study comparing fathers beyond the age of 50 with fathers above the or between 30 and 34 years, the risk of bipolar disease is nearly 3 times as high. In another study where this was looked at, they got a fairly, a slightly smaller number where the risk was 1.87. I seem to have lost some figures here. The confidence interval is not what it should be. So the bipolar risk of a bipolar disease in the offspring seems to be increased. Numbers a little different in different studies. For schizophrenia, I think maybe the easiest way to explain this, at least if we were to explain it to a patient, is that the overall estimation for the incidence in fathers below the age of 25 would be 1 in 141, and then it starts to go up so that in the fathers that are over 50, the risk is 1 in 47. So overall, we end up getting a relative risk of about 2 when the fathers are above 50 years old, as the older age meta-analysis gives us. And a very, very similar number has been reached in another meta-analysis. I think perhaps one of the key issues overall with this topic in general is how this may also affect the further generations. And as you see in the last key point, there is some evidence that the schizophrenia may also be affecting the following generation when the fathers are above the age of 55. Now, as I mentioned, there's the de novo mutations. They don't seem to be able to explain all of this increase. There is the epigenetic changes, the DNA methylation, and how the expression of the repressed genes is changed, maybe part of the explanation for this. Obviously, these are also other etiologies that come into play, and the older parents, the environmental resources have been offered as an explanation for this as well. Autistic spectrum disorders have been looked at. This is obviously something that I guess is largely discussed, whether the increase in incidence is real. At least here in Finland, there's a large ongoing discussion whether the diagnosis is reliable, because the numbers seem to go up very, very highly. But if we look at the existing data in a large cohort study of 4 million, the fathers that were above the age of 45, the incidence was about double for these compared to the 25, 29-year-old fathers. And it seems like the highest category associated with this was, the risk ratio goes up with each increase of 10 years with about 21%. And again, this may have an effect in the future generations, so that when we look at the men or the men who were 50 when their daughters were born, then looking at the next generation, irrespective of the grandchild's gender, you see an increase of 1.7, 1.8 in the risk of these autistic spectrum disorders. I have a trouble switching the, okay, here we go. Now, again, the attention deficient hyperactivity disorders, surely the diagnostics is a challenge, and you can see here that this is rather unconvincing overall, whereas this is a very, very common challenge. The Swedish study turns out with a 13-fold risk for the offspring of those where the father is above 45, and in a very, very large Taiwanese study, no such association or additional risk was available or obvious at all. There is a suggestion not only for the ADHD, that in some of these cases there is a J-shaped or U-shaped relationship between the psychiatrist, so that psychiatric problems, so that the younger fathers are in a high risk and sometimes even higher risk than the older fathers. Now, as I've mentioned, there's a huge difference in the findings in these studies. Childhood cancers is an important topic, and there are some specific diseases that have been blocked out. My first reference refers to an overall risk in the hematological malignancies, showing that if you compare the offspring of fathers over 35 to those below 25, you see an overall 63% increase in the risk. For ALL, the increase appears to be 13% for each 5-year increment in the father's age. Again, the Alderain paper, which deals with multiple endpoints, the risk ratio was somewhat less, showing only 1.08. For lymphoma, there appears to be a 3% increase each 5 years of paternal aging. Also, breast cancer and the cancer of central nervous systems has been linked to the aging paternity, and there you see a 5% increase every 5 years for central nervous system. For astrocytoma, it's somewhat more. Now, thinking again about the mechanisms, we do know that the older fathers will pass on longer telomeres for the offspring, and whereas this may add to their life in days, it will also most likely be playing a role in the increased risk of these cancers. So what should we then consider as an advanced paternal age? As you've noticed in the papers that I've referred to, there's very, very large variation. Looking at the significances, it's also difficult because the group where the comparison was made with varies quite a bit. But overall, I guess you could say that the risk of the offspring starts to emerge after the fathers pass the age of 40. And on the other hand, they are quite clear in the cases where they are clear once the father has reached the age of 50. The other thing which is quite clear that there's no such thing as a cliff where you see a jump in these risks, so that it's a continuum, and this is obviously very important when we are counseling the patients. Now, when the consultation or the counseling comes into play, I guess something like this could be presented to the patient or the client, showing the overall changes and additional risks that go together hand in hand with the aging father. Obviously, lifestyle choices, maternal age, and the couple's lifestyle choices need to be included in that discussion. So my conclusion is that it's quite clear that there are risks. However, they are less than the risks that are associated with maternal aging. I've run across the fact that several countries have limited the use of ART, or that's at least in the guidelines, to men that are under the age of 60. I've listed here a few countries or the age limits for sperm donors, which is obviously important as we consider the overall treatments. Whether there should be an age limit for people prior preserving their own sperm is a question. Is there pre-implantation genetic testing that should be available or advised for those where the father is of a higher age? So all these things should be discussed with the couples that are about to undergo ART. Finally, a few words about, with the research, what should be looked into. Obviously, the understanding of the mechanisms, be it epigenetics, de novo mutations, how all these things go hand in hand. The microRNAs, the non-coding RNAs, is obviously an interesting field. And the other thing is the long-term health of the offspring. Now, the other thing is that obviously the optimal situation would be that we could actually profile with these new techniques so that we could assess the risks and perhaps find biomarkers that would guide us with the ART success, and obviously highlight either the health or the risks more clearly in the offspring. And then finally, interventional studies, how we can avoid the risks that are involved in the advanced paternal aging. So to end my presentation, most of the papers that you read will start with saying that the paternal aging is an ongoing process. However, this recent paper gives you an idea that in the early, 100 years ago, we actually were older, at least in Sweden and some other countries, compared to what the situation is at the moment. Thank you.
Thank you very much, Antti, and thank you for the questions in the chat box. I'd like to, I think there are 3 or 4 questions there by Roman, Sezin, Anastasia, and Tomomoto. Thank you. Most of them were responded probably in your conclusions regarding cutoff limits and age limits. I think that's still under discussion, but there's also a question by Sezin Carsley. How do you compare the impact of paternal age and maternal age in terms of the miscarriage risk? And if you think there are synergistic effects when both parents are older?
Well, the last part I think is easy. It's quite clear that there's a synergistic effect but I would say that it's quite obvious that the maternal part plays a bigger role as far as we consider the age. But I think also studies that have either been with the donor oocytes or with the younger female couples, it's quite obvious that the male partner does play a significant role. But I think, as we know, in a lot of cases, the older father the couple will be older as a whole, and that's exactly the issue where the risks are highest. I think that's where the PGT comes into play and should be at least discussed.
Thank you very much, Antti. In benefit of time, I'll turn it back to my colleagues from ISA for the next presentation. And Antti, if you wish, you can reply in the chat box individually to the questions. Thank you very much.
Thanks.
Thank you. Thank you, Marcos. I'm Giovanni Corona, the secretary of the ISA. It is a pleasure to share this fantastic educational activity. We started a great collaboration since more than 1 year ago, and the great success of these webinars can justify how it's important for both societies. So it is my pleasure to present Edgar Moncano. Professor Moncano is the current president of the IFFS. So Moncano is going to release a talk on oncofertility in males. Please, Edgar.
Dr. Corona, thank you very much. It's a pleasure being invited here at the strong collaboration between ISA and the IFFS to bring the topic of male fertility to the forefront. Nearly all the meetings that we attend are dedicated to either ART or female fertility, but to discuss males and specific aspects of their care is something different. Maybe can we confirm my slides can be seen easily?
Can't see them at the moment. If you could reshare.
Please share.
Okay. So just I'm doing it now.
Thank you.
Thank you.
Yes, it's just
Excellent.
in
Good. I'll place it in presentation mode in a moment. Okay. So pleasure being here. I have nothing to disclose. I operate in this hospital, a maternity hospital that was founded in 1792. And the 4 educational objectives of my presentation are reasonably straightforward. To understand the impact of cancer and its therapies upon male reproduction, to observe how male oncology preservation service can and should be organized, to learn what services can be offered and what the consent should include, and identify opportunities for survivors. One wishes to search for the last 10 years publications related to male oncology, fertility preservation. There are not many publications, approximately 704. Yet this is a very important topic for a silent population, males. We know how reluctant they are to come forward. Here, this table shows the 3 most common cancers in patients of different ages. And it's very intriguing to note how prepubertal boys suffer with leukemia, brain cancer, and lymphomas, while as they advance in age, testicular cancer, the highest risk in the 15 to 44, bowel and skin. And for older men, prostate takes a preponderant role, followed by bowel and then oral cavity in young adults, lung and bowel. So what cancer therapies will be employed in male patients undergoing investigations and therapy? Surgery, of course, could be orchidectomy or could be surgery related, for example, to tumors in endocrine organs situated in the brain, followed by chemo or radiotherapy, or followed by no intervention whatsoever, just curative surgical procedure. Exceptionally, a bilateral orchidectomy is required, yet there are many situations in which a brain tumor, as we've seen, children suffer with brain tumor, hypothalamic pituitary axis is affected, both by the surgery itself or by the subsequent radiotherapy, particularly localized radiotherapy. We know for a long time that chemotherapy affects reproduction both in females and in males. In males, alkylating agents are most toxic, resulting in 90% in azoospermia, and there is no evidence of a high rate of DNA fragmentation compared to healthy controls in samples after chemotherapy. Yet we must acknowledge that chemotherapy regimens have changed quite a lot in the last 20, 30 years. Radiotherapy is far more severe. A low dose of radiotherapy, up to half a gray, results in just suppression of spermatogenesis. Anything between 2 and 3 results in azoospermia, but with a recovery in approximately 3 years. Higher doses, some recover, and over 6 gray, the risk of permanent sterility is there, but most likely 100%. What is nevertheless observed is that in radiotherapy treated patients, male patients, there is an increased risk of sperm chromosomal abnormalities once spermatogenesis is restored. And I go back to this slide. This is a nice electron microscopy of one seminiferous tubule with sperm with tails towards the center part of the tubule. I found this graph quite interesting, and that's why I'm presenting it here. It just shows that the incidence of cancer at different ages is higher in early years for the female. You can see up to approximately 55 to 59, followed by a reversal of trend with males now having more diagnosis of cancer as they advance in age. And I think this is quite interesting, so keep this in mind because I will show some data on uptake of fertility preservation for males. Whenever we deal with cancer patients, we need to keep in balance the life-saving cancer therapy and the preservation of fertility. And while in females, there is a relatively lengthy process of retrieving that tissue from the ovaries or the oocytes after stimulation, in males, the process is far easier. So when an oncofertility service is set up, a patient flow should follow 3 important steps. The organization of an appointment following referral, presence of dedicated staff, seen within 24 hours. Of course, in Europe, we have blood testing to ensure viral screen negativity, and then information to patient given. Then the consultation, which includes counseling, which includes cryo advice, consent discussion, signing, and of course cryopreservation. And then following cryopreservation, continuous contact with the patient and contact with the referring services, namely the oncology services. The patient journey map can be summarized in these 6 steps. 1 is referral, 2, a counseling session, 3, medical consultation, 4, informed consent, 5, treatment plan or intervention, and a follow-up. And in this process, multiple elements will come together: the presence of a counselor, a fertility specialist, and sometimes an andrologist, an embryologist. For example, if the man produces a semen sample and he has no sperm whatsoever, it will be good to have an andrologist explaining the findings at the time of analysis. Essential are the patient information leaflet. Patient needs to know about the service before they even reach the door. A referral form that introduces the patient to the cryopreservation services and detail the patient's background, the diagnosis, the likelihood of survival, and potential treatments, which should include the use of surgery, chemo, or radiotherapy, and of course, a consent and a feedback form to the referring physician. Examples of information leaflet can be done for both men and women, and there is an example of one that we used here in our services. The reproductive system, how does it operate? What happens in the reproductive system in men and women? What does the process of cryopreservation involve? This obviously is for the females. And then what happens after the cancer is cured and what therapies they might contemplate once they have survived therapy. The referral form, just a simple example here, I recommend that each service will develop a form for their own needs, but should include quite detailed information in relation to the patient background. As I said, cancer diagnosis, what surgery has been performed or planned, if chemo or radiotherapy are planned, what stage the disease is, and so on and so forth. It can be done also electronically, where it's very easy to have an electronic referral form where the oncology services already input all the information that is then read and received and read by you, the people that do the cryopreservation following consent. The consultation with the physician must bring to the fore a good understanding of the patient and its background, establish if the patient is suitable for cryopreservation, far more relevant for females than for males, a discussion of all needed and offer opportunity to ask questions, and then obtaining informed consent, which is a legal document and must include everything that was discussed. Finally, the aim of the consultation prior to consent is to establish if it's safe to proceed with the cryopreservation, if the benefits of proceeding with therapy outweigh any risks. In males, there are very little risk if the male can produce a sample, yet there might be patients that cannot produce a sample. There might be patients that need testicular biopsy. There might be patients that need electroejaculation. So this needs to be all brought to the fore. Are the chances of a pregnancy realistic? In other words, if the male partner, the female partner has a very low likelihood of obtaining a pregnancy, how realistic is this freeze? Are there any contraindication? Does the patient understand both the risks and the benefits? And is it okay to delay the cancer serving services? The informed consent should include the possibility that sperm quality is severely affected. I will show you some data. The discussion of available cryopreservation methods, which in males that can masturbate, it's easy. The likelihood of material survival after thaw based on quality at freeze. The potential need for more than one sampling. The likelihood of a pregnancy after the use of the cryopreserved material. The duration of cryopreservation, which could be 5 years, 10 years, and the possibility to re-sign the consent for storage afterwards. The health of the future child, and no better presentation that my predecessors that clearly showed that risk to the child, never mind cancer, is also related to the age of the male. And of course, they need to contact cryopreservation services on an annual basis. There's nothing worse than not knowing that a patient has passed away or does not wish to continue storing their cryopreserved material. Certain aspects that are rarely discussed but are crucial in terms of need to be included in the consent are legal aspects like the need to support and respect patients' wishes, the need for the services to mitigate potential future claims by relatives, and the provision for specific actions in the cases where the patient does not survive its cancer therapy. For example, thaw and disposal of the sample without reproductive use of the sample posthumously by a named partner, and the name needs to be in the consent, donation of stored material to a third party for reproductive purposes, or donation of stored material for research. So what are the avenues before cancer therapy? Well, there are, as already mentioned, very simple, prepubertal, testicular tissue. This is still experimental. It should be only performed in the circumstances of research projects. Post-pubertal semen cryopreservation has well-documented benefit and should be offered to all males undergoing sterilizing therapy. It could be ejaculated sperm, could be electroejaculation, or a testicular biopsy. Or in the cases where the treatment affects the hormonal axis but no adjuvant therapy, there is really no need to cryopreserve because hormonal replacement at a later stage could help the patient restore spermatogenesis. The first challenge that any service provider will have is firstly the fact that the uptake of cryopreservation is disproportionate to the number of patients that are diagnosed with a particular cancer. So here on the left-hand side, you will see the age distribution of patients that attend for cryopreservation, and largest number of patients is between 20 to 25, followed by 26 to 30, followed by 31 to 35. Yet, out of the total, on the right-hand side, out of the total testicular cancer diagnosed patients, only a fraction are referred for cryopreservation. Vast majority are not referred. And this is the case across the spectrum of diseases that require therapy. The sperm quality before cryopreservation varies. And very important to realize that not all males that come to cryopreserved sperm will have any sperm present. In fact, this is data from paper by the Italian group published in 2016 that looked specifically at Hodgkin's lymphoma, but showed a literature review of what is the percentage of vasospermic males in males referred for semen cryopreservation. And you can see it could be as low as 2.6%, as high as 11%. So men need to be prepared that there might be no sperm to cryopreserve. And this thing of cryopreservation, we might think that it's only a modern technique. That's not quite true. Of course, this is Leeuwenhoek who first described the presence of sperm. And sperm has been slow frozen since 1953. It's obviously currently stored in liquid nitrogen at minus 196 degrees. Excellent survival. It can be used for very, very, very long-term storage, and maybe ideally vapor phase liquid nitrogen to reduce the risk of cross-contamination. These are the very first experiments with glycerol. Could provide protection to cells at low temperature, and this was 1949. The first pregnancies from AI, artificial insemination with frozen thawed sperm, or by Sherman and Bonk in 1953. And here in Horn in 2004 presented the birth of a live offspring utilizing sperm that has been cryopreserved for 21 years. So we can see that a very long-term cryopreservation of sperm does appear to be useful for reproduction. What can be done after cancer therapy? Of course, there might be the return of spermatogenesis, in which case a spontaneous pregnancy is very much possible. If the hormonal hypothalamic pituitary testicular axis has been affected and no chemoradiotherapy has been used, then FSH and LH for replacement to stimulate spermatogenesis is the way forward. And of course, providing the female is healthy, a spontaneous pregnancy can occur. The male is azoospermic and he has frozen sperm. All three procedures, if the semen quality is very good, large number of vials, female is young, no female factor, artificial insemination could be used for some of those vials. Similarly, both IVF and Dixie can be used depending on the sperm quality. If the male is azoospermic and no frozen sperm present, in that case, it is obvious that donor sperm therapy is the only avenue. This is a graph from United Kingdom that shows the cancer survival in England between 2016 to 2020 with a follow-up in 2021. And you can see a very large percentage of patients diagnosed with testicular cancer, melanoma, prostate cancer. The ones for males are mainly in red. Larynx survive their malignancy. So they will be candidates for cryopreservation because they will come in asking to have a family. And these are trends, and we can see that throughout the years, the survival rate has constantly increased from, for example, a testicular cancer, barely 65 in the 70s to in the late 1990s, over 90%. So more and more and more of these male cancer survivors will attend our services. So we need to ensure we cryopreserve sperm for them at the beginning. There's some good evidence that spermatogenesis is affected by chemotherapy, but not as severely compared to radiotherapy. And different types of protocols, which are here, will affect spermatogenesis. Nevertheless, vast majority of patients that only received chemotherapy will have a return of spermatogenesis. Things are a little bit different in terms of radiotherapy, as the higher the dose of radiotherapy, the more likely that the male will be azoospermic afterwards. This is published data that looks at patients that had sperm frozen. So here there's no data on how many were azoospermic before, but what I would like to show you is that 75%, the columns in green are the patients before the chemoradiotherapy. So 75% of all sperm cryopreserved had normal parameters according to the WHO criteria. Oligospermic 17, 9% severe oligozoospermia, and of course none or zero azoospermic. Yet in brown, you see the percentage of patients that belong to each of these concentration categories after therapy, when a routine semen analysis is done 1 year or no later than 2 years afterwards. So the most drastic finding is that only 37% have normal semen analysis 1 year afterwards, and that 21% of males have no sperm whatsoever after chemo or radiotherapy at a repeat semen analysis post-treatment. So this is the target population for cryopreservation. 1 in 5 men have no sperm. We need to help those people freeze the sperm before and have it for use at a later stage. So what are the reproductive outcomes? Post-treatment, males that had radiotherapy have a lower chance to achieve a pregnancy compared to the ones after chemotherapy. Nevertheless, approximately 65% of males conceive after cancer-saving therapy with a follow-up of 7.8 years, and the pregnancy rates after 20 years of follow-up could be up to 47%. These are spontaneous pregnancies. And of course, one of the most challenging questions is how many patients really ever come back to use this frozen sperm? And this is audit that looked at close to 1,200 cases referred for cryopreservation. 11% could not produce a sample, so that's something you need to remember. Around 1 in 10 men either do not have sperm or they're unable to produce a sample. Suitable for cryopreservation, the remaining about 8% will die after treatment. Some will require sample disposal, 2.9%. Others transfer their sample. Return for semen analysis, very few, but return for IVF, approximately 5-6%. And these are 58 patients that came back for IVF. We asked a few questions. The first one was, does the outcome of IVF or ICSI change if we use frozen sperm for social reasons? These are not cancer patients, compared to frozen sperm from cancer patients. So you can see ICSI treatments with frozen sperm for social reason, pregnancy rate 33%, in oncology 39%. IVF frozen 36, IVF oncology 44. So the sperm frozen for cancer patients offers the same opportunity to conceive with ART as for men that don't have cancer and had to freeze their sperm. And when you specifically look at the patients that returned for IVF or ICSI and also had frozen embryo transfer cycles, pregnancy rates are very good. This is 84 cycles started, 94% had an embryo transfer, and clinical pregnancies per cycle started 44. Obviously, these are studies that are not very recent, but it's not easy to find studies that look at ART after the use of male reproductive material. I found this interesting paper, and the senior author is actually one of the chairs today. And I'm giving you only one of the findings. And this was a very intriguing paper. It looked at the long-term effect of cytotoxic treatment on sperm DNA fragmentation in patients affected by testicular germ cell tumors. So they've asked the question, does the sperm DNA fragmentation return to normal, and how long does it take? And you can see that a vast majority of patients are considered okay to try to conceive after 2 years, but the DNA fragmentation rates remain still high for many of them, so 3 years appears to be more appropriate to wait after treatment of testicular germ cell tumors, such testicular tumors. But the most intriguing paper that I've seen, and one that I think probably will have a significant clinical impact in terms of offering reassurance to couples, is this one from Anti's country, Finland. This group looked at longitudinal trends in testicular volume from puberty to adulthood, sperm quality, and paternity outcomes after childhood cancer. There was a 17.2 years follow-up. This is just published. It's published in January 2025. 1 in 3 patients had azoospermia as adults, and 38, close to 39% of patients had father children. And you can see there's a significant difference here between on the left-hand side is radiation, and on the right-hand side is chemotherapy. And you can see that if the dose of radiation was higher than 1 gray, the testicular volume was significantly decreased compared to if the radiation was not employed, while the difference was not present if chemotherapy was used. So it appears that radiotherapy is severely affecting testicular volume. And in consequence, the same is valid for the sperm concentration or sperm count, in fact, here. So total sperm count in million per mil. If a higher dose of radiation was used, you can see how flat the green line is as opposed to none, where the continuous improvement after 10 years, 20 years, or age of the male is. And in chemotherapy, you can see an immediate recovery if a low dose or if certain regimes of chemotherapy less than 12 courses were used. So this is a very important paper in terms of advising parents of children, male children that are diagnosed with cancer and undergo chemoradiotherapy. I identified 2 areas of future research. One would be new techniques of preserving and storing sperm, and I think we can do better than storing it in minus 196 degrees Celsius in difficult environments and costly, and also assessment of sperm quality before freeze. With that, I conclude that oncology cryopreservation should be offered to all males that undergo potentially sterilizing life-saving therapy, as it is safe, proven, and effective. Consent must be comprehensive and include ethical, legal, and medical details. Prepubertal tissue cryopreservation and grafting remains experimental, used only part of research, and MAR after survival offers realistic chances of conception. Some references, the American Committee Opinion and the Lancet Oncology group by René Mulder. And of course, I'd like to say thank you once again for your presence and attendance, and invite you to the IFFS World Congress, which will happen in 3 months in Tokyo, April 26th to 29th. Thank you.
Thank you, Edgar. We are a little bit out of time, so if you agree, we can listen to Giampiero Palermo lecture and then maybe maintain a couple of minutes of discussion. So please, Cilla.
Yeah, thank you very much, Giovanni. So I am also representing the ISA, and actually I was the past president of the European Academy of Andrology, which is a member society of the ISA. So it is my great pleasure to introduce to you the next speaker, Dr. Giampiero Palermo, who is a worldwide well-known, famous expert in reproductive medicine. Actually, he was the first one who described the intracytoplasmic sperm injection in 1992. And since then, he is working in the field of reproductive medicine. And he is the director of the Assisted Fertilization and Andrology at the Perelman Cohen Center for Reproductive Medicine. Who else then Giampiero could talk about the the reproductive technologies which we can use in male factor infertility. So please go ahead. Thank you.
Hello, ladies and gentlemen, dear colleagues. I would like to thank Dr. Horton, Kraus, and Corona for the kind invitation, for allowing me to participate to this webinar. So I'm going to share with you medically assisted reproductive technology as a treatment for male infertility. So if we exclude about 1/3 of the indication for infertility between unexplained and combined is equally distributed between the female and the male partner. Now, when we evaluate the male partner, we assess the developmental history, medical history, family, surgical history, as well as sexual history. Then we perform a physical exam, but everything pivots around the semen analysis. If the semen analysis is normal, then we focus on the female partner. If he is abnormal, then we perform additional tests to assess if there are hormonal imbalance, etc. In the US, particularly, we do this together with the reproductive urologist. And then we try to optimize this accordingly. Once they're optimized, then we focus on the best male treatment, particularly through assisted reproductive technology, whether it's IVF or ICSI. So the semen analysis, as you know, according to the WHO criteria in 2021, we have ancillary parameters such as abstinence, volume, and viscosity. The most important are concentration and morphology. Motility, if present, otherwise we assess the viability or the presence of other cells. So regarding the treatment of male infertility, it's important to consider that these men have also genetic abnormalities such as chromosomal abnormality. This is a sample of 1,500 men, Japanese men, that have autosomal abnormality, 126 cases, and a gonosomal abnormality, 99, and mainly are for the gonosomal Klinefelter form, complete or mosaic. So we have an overall incidence of 13% of chromosomal abnormality, and we have performed a similar study here in the US at Cornell, and we have between 12 and 13% of chromosomal abnormality. So it is important to consider this while treating these men. In addition, it's important also to look at small abnormality, particularly the Y chromosome, such as Y chromosome deletion. You see here is a PCR plate where you see the base, there are the bands that are actually present in the normal male. The tip of the arrow indicates the missing bands. In this particular case, we have 8 sequence tag sites that are missing in this individual. And this goes inversely related with the concentration. Indeed, the incidence of Y chromosome microdeletion increased with a reduction in concentration, being in the esospermic men as high as 9 to 10%. Fortunately, if we retrieve spermatozoa in this individual, whether from the ejaculate or testicular, there is, although a concentration can vary between 3,000 to 2.5 million, you see that the fertilization rate between 40 and 54%. And the clinical pregnancy rate is about 36%. When I mentioned throughout the talk clinical pregnancy rate, that means the presence of at least one fetal heartbeat, not just the sac. The treatment for male infertility is performed mainly by ICSI, intracytoplasmic sperm injection. It requires sophisticated equipment where to reduce the motion. It's normally done by hydraulically controlled joystick. And then here below, you see the ICSI dish. There is in the middle the spermatozoa, and the surrounding droplet contain each individual oocyte. And this is a horseshoe-shaped, custom-made eating stage. Just to show you the difference inside between the male and female gamete, it's interesting that with ICSI we bring down the ratio to 1:1 between the male and the female. And then this is how you can see the procedure requires a little bit of skills. So looking at assisted reproductive technology performed at Cornell, while Cornell Medicine in the last 30 years, we have performed 62,000 cycles. And if you see here, the incidence of ICSI were about, in 1993, when I joined the Cornell group, was about 30%. And progressively, each year thereafter increased to go since 2020 at about 90% and over. The last year there, about 99%. I mean, this is probably because we work together with a reproductive urologist very close, so we have a referral of a large proportion of male factor patients. When we look at 46,000 cycle of ICSI, we have the large majority that perform with about ejaculated spermatozoa, 91%, the remainder with surgically retrieved spermatozoa. If we look at the characteristic of this 42,000 cycle with ejaculated spermatozoa, we have a maternal age about 38 years of age with plus minus 5 years of standard deviation. When we look at the semen parameter, about 70% are apparently normal, while the large majority have at least one parameter compromised. So when we look at the injection of M2 oocyte, we had 357,000, 97% of those survive, and 78% of those oocyte injected fertilize normally at 2 p.m. There is an additional about between 3 and 6 p.m. and 6% of abnormal fertilization between 1 and 3 p.m. We look at the different semen origin and an ICSI outcome, whether the sample is ejaculate, electroejaculate, or retrograde ejaculation, whether fresh and cryopreserved, we still have a fertilization between 74 and 78%, with a clinical pregnancy ranging between 37 and 46%. We look at cases where the concentration of the spermatozoa is less than 1 million. In these 2,400 cycles, we have about 200,000 spermatozoa as an average, 18% motility, and 1% morphology. The fertilization is still 61% with a clinical pregnancy rate of 50%. There are some cases when we found some individual spermatozoa, and we call it cryptozoospermia or virtual exospermia, where in the past we just called exospermia, where we don't see anything in the microwave chamber, and we need to spin the sample in order to retrieve some spermatozoa. This particular case, 70,000 spermatozoa, the concentration after centrifugation, with a motility of 17%. The morphology is not possible to assess. The fertilization rate is 53%, with the clinical pregnancy rate of 53%, very encouraging. When we look at the indication for male infertility, we have all varicocele, cryptorchidis, and other causes can actually reduce or compromise spermatogenesis, but the most important, in about 30% of the case, 29%, is the exospermia, which is equally distributed between obstructive and non-obstructive. So in case of ICSI with exospermia, we have performed 3,500 cycles. The maternal age is younger, 36 years, still with a big standard deviation of 5 years. We have about 1/3 of those performed with epididymal spermatozoa, 1,300, and the testicular spermatozoa, 60%, over 2,000. When we look at the obstructive exospermia, mostly it's congenital bilateral absence of the vas deferens, unreconstructible vasectomy, infection, or trauma in cases acquired. So the procedure to retrieve the specimen is percutaneous epididymal, or this open approach of epididymal aspiration, which has been mastered and developed here at Cornell. And then when the epididymal approach is not feasible, then we perform testicular percutaneous aspiration. So for the epididymal cases, we have between congenital and acquired indication about 600 cycles. You have here the concentration range between 12 and 16 million, the motility in 6 and 7%, and the morphology of 1%. The fertilization for the acquired is 70% versus for the congenital 72%. The clinical pregnancy rate is also slightly lower for the acquired, I would say mathematically different, but clinically comparable, a 47% for the acquired and 55% for the congenital. Now, in case when the epididymal approach is not feasible, we move to the testicular sampling. For the testicular sampling performed in an obstructive patient, obstructive men, we have 337. In all of them, we are able to retrieve spermatozoa. For the non-obstructive, only 62% we actually retrieve spermatozoa at biopsy. For a non-obstructive exospermia, the histopathology characteristic is, fortunately for half of the case, is hypospermatogenesis, where if we search, we look through the testicle, we are able to identify foci of spermatogenesis. Unfortunately, for the remainder, is equally distributed between maturation arrest, Sertoli-Zanoni syndrome, where no injectable spermatozoa are retrieved. Excuse me. The testicular biopsy is, this is the standard fashion, with an incision through the tunical bugina and squeezing some seminiferous tubule. But what we have developed and mastered at Cornell is the microthese, where actually we identify the largest seminiferous tubule residual of foci spermatogenesis. When we look at the result here, 336 for the obstructed, 1,700 for the non-obstructed, the concentration change between the obstructive 8 million versus 200,000 for the non-obstructive. The motility between 3% for the obstructive and 1% for the non-obstructive. The morphology, I would say, is sui generis, so not accessible. So we have a fertilization of 66% for the obstructive and 47% for the non-obstructive. The clinical pregnancy rate, 43% for the obstructive and 38% for the non-obstructive. So if we look here, whether we use a fresh sample here in green or a cryopreserve in blue, the fertilization rate for the ejaculate is comparable at 75%. For the epididymal, 70% for the two samples formed. And for the testicular, barely shy of 50%, but comparable. When we look at the clinical pregnancy rate with the epididymal, we have a 61% clinical pregnancy. With the testicular, with a fresh specimen, as 45%. If we look at the cryopreserved specimen for the epididymal, it's 46%, and the testicular, 38%, respectively. And within each procedure, the fresh specimen outperformed the cryopreserved. So it is important to consider that the DNA organization in the male gamete is unique. It is most of the DNA supercoiled around the toroid-shaped core of protamine. There is, however, some 16 to 20% residual nucleosome, which is the DNA surrounding histone, and these are more sensitive to damage that can be measured by different assays, and we call it DNA fragmentation assay test, which we use mostly the sperm chromatin structural assay, the gold standard, or the tunnel assay. So we performed this study here at Cornell, published on the Journal of Urology, and this was done in 2020, where we performed this assessment in men that have a high DNA fragmentation in their ejaculate. We have 38% with the SESA and 33% by tunnel assay. So we went, the patient consented to a testicular biopsy. We went to the vas deferens and we performed, we retrieved a specimen that was assessed by tunnel, and we found about 18% and 23% of DNA fragmentation. There is to consider that the threshold for tunnel is 15%. So if we go proximally at the epididymis, it's about 15 to 16%, just at the threshold. And if we retrieve spermatozoa from the testes, it's perfectly normal. It's a lower DNA fragmentation. That's interesting. As proximal we go, healthier is the spermatozoa. So if we look at the data in this individual, we see that the fertilization is 66% if we use a specimen from the ejaculate, with an implantation of 3% and a clinical pregnancy only 6%, with a delivery of barely of 4%. But if we use surgically retrieved spermatozoa in these men with high DNA fragmentation, we are able to get comparable 60% fertilization. But in implantation, they rise up to 13%, the clinical pregnancy 29%, delivery of 22%. So, but not all men would like to have a testicular biopsy, especially if they are aware that they have a spermatozoa in their ejaculate. So we look at this paper we published a while ago in 2014, called a perspective on the assessment of human sperm chromatin integrity. And the most important message was that there is a clear inverse relationship between the DNA fragmentation and the motility of the spermatozoa. So we thought maybe if we select the most motile spermatozoa, for example, in this micro chamber, the microfluidic chamber, actually the chamber that we use is this one, 800 microliter, maybe we can identify spermatozoa that have a higher DNA integrity. So this is a paper, the pilot paper, or Parella et al., where we assessed 69 men, and we did the density gradient and microfluidic. You see the sample, the volume decrease, obviously. The concentration decreased from 28 million in the raw specimen to 17% density gradient, 8% by microfluidic. The motility from 33% in the raw specimen, double 60% in the density gradient, but became 97% by microfluidic. And the morphology improved somewhat from the raw specimen, not in density gradient, but it does in microfluidic significantly. And this is the characteristic of the sample, the raw sample in the micro chamber, the sample processed by density gradient, and here by microfluidic, you see is the motility is 100% here. So we perform another study, this is from Kokura et al., and it's actually in 2022 in Andrology, Journal of Andrology, where you can see here that in the raw sample we have 26%, by density gradient improved to 18%, by microfluidic is barely 2%. So these are 80 couple treated by density gradient in 191 cycles and in 90 cycles by microfluidic. The maternal and paternal age are comparable at the same patient, their own control. You see that the fertilization rate is similar between the two preparations, sperm preparation, between 66 and 68%. You see, if you use the density gradient treated specimen, the implantation rate is 8%, the clinical pregnancy is 17%, delivery of 7%, with a very high pregnancy loss. But if you use microfluidic, we have a 23% implantation, 41% clinical pregnancy, delivery of 36%, and a very minute pregnancy loss. Then we read a paper from Casanova et al. On fertility and sterility that indicate that actually it's not a total DNA fragmentation that we can assess by tunnel assay or sperm chromatin structural assay responsible for the pregnancy loss or the inability to achieve a healthy pregnancy. So, but it is the double-stranded DNA fragmentation. And this can only be assessed by this assay, the COMET assay, the neutral COMET assay. You can see here in the 0 is no DNA fragmentation, and you get all the way to 4, number 4, with the extremely long COMET. So with this, we reassess our sample by tunnel, the total DNA fragmentation, see 26%, by density gradient 18%, and a 2% microfluidic. If we look at the double-stranded DNA fragmentation, the putatively is responsible for the structural chromosomal abnormality of the conceptors. You see there's about 3.6% in the raw specimen, still 3% by density gradient, but my microfluidic is very minute, almost negligible. So we did the study here, assess 85 couple. We have this cycle, 88 by density gradient and 86 by microfluidic. Maternal and paternal age is also comparable. Again, also in this case, the patient had their own control. The fertilization rate with density gradient is 67%. It began by microfluidic 78% already. If we look at the euploidy embryo obtained by density gradient is about 24%, but microfluidic is almost double at 43%. When we look at the clinical pregnancy that we got by density gradient, the implantation rate is 6.7%. The clinical pregnancy is about 10%. No delivery with all pregnancy loss. But if we use the density gradient approach, the microfluidic approach, the microfluidic approach, we have 65% implantation rate, a clinical pregnancy also 65%, and similar 60% delivery rate with very minute pregnancy loss. So if we look at the overall result with the standard in vitro insemination for this time period, in these 30 years, we have a 60% fertilization rate, about 40% clinical pregnancy, 35% delivery. With ICSI, we have higher fertilization rate, but if we check when adjust the denominator instead of the M2 for the retrieval site, like for standard in vitro insemination, you see that the two techniques in terms of fertilization, clinical pregnancy, and delivery overlap almost identically. The difference is that with ICSI, you can treat couples that cannot benefit first by standard in vitro insemination. And at Cornell, we have well over 25,000 baby born so far through these two procedures in these past 30 years. So a bottleneck of our success rate is determined by the maternal age. If you look at the delivery rate at age 35, it's 42%. At age 39, decreased to 32%. And from 40 years onward, progressively decrease to be at age 46 and older, almost an older, 3.5%. So we also have been assessing the overall health of the offspring. We did several studies through the years at age 3, at age 5, and this has been done together with Center in Göteborg and in Belgium. And you can see here the most recent data from Cornell. This is a publication of 2021 on American Journal of Obstetrics and Gynecology. We have about 16 years, the span of the study, 2,300 children, 451 from IVF, 1,100 from ICSI, use a parent-administered questionnaire. We have child development with ages and stages questionnaires, most popular questionnaire here in the US, or the child behavior checklist for the child behavior, parent stress index, and social skill rating system. You look at the result here, IVF and ICSI participants had a comparable obstetrical and perinatal outcome. You see, fewer IVF conceived children display abnormal development. This was interesting and reassuring. The degree of spermatogenic failure, whether it was DNA integrity or the exposure to chymotrypsin and petoxifyline, did not affect the ICSI children development. And among the ICSI children, we noticed that those conceived from surgical retrieved spermatozoa had a lower risk of abnormal development than children conceived from ejaculated specimen. And interestingly, the rate of abnormal behavior was higher in the children conceived from day 3 fresh embryo transfer. So if you look at the ICSI landmark, you see that since its development implementation in 1992, it took about 2 years to be used in testicular epididymal spermatozoa, additional time to be used in cryopreserved epididymal and testicular spermatozoa, as also it has been instrumental in the development of oocyte cryopreservation. Most of the center utilized in PGT-M for a single gene defect, and obviously for in vitro maturation of oocyte. So if you look at the indication of ICSI, everybody would agree that it's used for male factor, whether ejaculated spermatozoa with retrograde ejaculation, globosospermia, or cryptosospermia. If we use epididymal, testicular spermatozoa, whatever the reason are, but certainly everybody would agree that ICSI is the ideal treatment. And for non-male factor, these are somewhat controversial, whether to utilize ICSI or not, but that's depends from the center and the country. But here at Cornell, we use for low number of oocyte, advanced maternal age sometime, cryopreservation of oocyte, PGT-M, or HIV discordant couple. In some countries, used for restrictive legislation. These are the more recent data for the Institute, for the International Council Monitoring Assisted Reproductive Technology. These are data published in 2024. And you can see that these are the countries in yellow that offer ICSI and IVF at the equivalent rate. And these are the countries in light blue that offer ICSI at over 80%. And these are the countries that almost exclusively offer ICSI in dark blue. So these are for just the year 2016, 79 countries. You see that the number of ART cycle is 1,500,000. It's about between IVF and ICSI. With about 723,000 children born, over 50%, 56% from ICSI. So if you see the trend, you see that assisted reproductive technology has increased, at least here in the US. These are data from SART 2021. And so you can see that the number of PGT cycle has increased as well. And this may explain why we use more ICSI. And then oocyte cryopreservation also have been progressively increased from 2009 to 2021, according to SART. So they would explain a little bit why ICSI for non malfactor infertility is being used. If you look at the fertilization rate, you see here 70% with standard IVF, the clinical pregnancy 40%, similar 35, 38% delivery. If you use ICSI for non-malfactor, the fertilization rate is higher. The clinical pregnancy rate and delivery is identical. If you use ICSI for malfactor, we have an excellent fertilization rate and a clinical pregnancy rate that is comparable to the other one as well as the delivery. These are data from Cornell in the last 30 years. So we can conclude that ICSI is the ultimate treatment for male infertility. I believe that everybody would agree that the quest for the ideal spermatozoon is promising, and that's because of ICSI. ICSI allows verification of oocyte maturity. There's some other ancillary usefulness of the procedure because we remove the cumulus cell, so we know that the oocyte is actually mature. The ICSI is more sensitive and precise, so some centers have more difficulty than others in performing and ensuring this consistent outcome. And we can say that ICSI is actually versatile. And I would like to acknowledge all my collaborators that through the year have helped me to put together this talk. Thank you.
Thank you
So
very much. Yeah, Giovanni, please go
No,
ahead.
thank you. Just we are a little bit out of time, so I think we can, if Marcos agree, just to have two quick questions with quick answer. The first one is from Edgar. Edgar, are you still with us?
I am indeed.
So just, yeah, I can hear you. Just a comment from my side. Despite your great talk, I think we are still seeing people without any suggestion after cancer of cryopreservation before cancer. So before any treatment, chemotherapy, and so on. So I think that from both sides, from IFFS and the ISA, we need to emphasize this issue and to work together in order to avoid this not good practice. What do you think, Edgar?
Could not agree more. And I think I've showed those two clear graphs on testicular cancer and so on, but the situation is probably all around the world the same. Some countries do not have national programs. We're lucky in Ireland, we do. We need to act on two fronts: education of oncologists and two, education of patients. I think information about fertility cryopreservation, and both men and female, should be part of the oncology consultation.
Thank you, Cilla.
Yeah, so again, thank you, Giampiero, for this comprehensive and very nice overview. So only one question. You know about the papers from Belva when they were following up ICSI young adults, and they found that there is a higher incidence of oligozoospermia in these children born from ICSI. And we in the field of andrology, we always think about the possibility that, especially when we are using spermatozoa from idiopathic infertility, we may risk to transmit infertility through generations. So I think that it's a wonderful technology. We are very happy that it exists, and it is, as you say, it is the ultimate therapy. But there are, especially for those cases where the reason for azoospermia or severe oligozoospermia is not known, and we think that there is some genetic factor which can be actually transmitted. So I think that I don't know what is your view on that, but I think we really need to do a lot of studies on the genetics of male infertility to find out which are those genes or genetic factors which could be transmitted thanks to this technology to the next generation.
Excellent. Yes, thank you for the question. I agree with you. It's a very astute point. I would like to kind of point out the assessment from Belva there on the young adult. They the semen parameter were within the normal limit, were just lower than the individual born from natural conception, but they're still within the normal limit. So they were non-oligoisospermic. They were just slightly normal than lower than the control. Regarding ICSI, true. With ICSI, we risk, with any assisted reproductive technology, we risk to reproduce or project to the progeny their genetic defect of the parents. But that's true also with simple reproduction. If there is an inheritable disorder in the parents with natural conception, you are passing on to the progeny. And we accept that. So I think we should respect the wish of the couple. If they wanted to reproduce, we offer the tool to do so, but we inform them of the risk they're taking. The fact that the individual has certain genetic abnormality, I agree with that, and that's the reason we're doing genetic and epigenetic assessment of spermatozoa to see what is responsible for their azoospermia. And but if they decide ultimately to have an offspring, that child may have oligospermia or azoospermia, and so the same with the transmission of the Y chromosome microdeletion. Same thing. It's up to the couple and not up to us if they should reproduce or not.
Yeah, no one is questioning, but I think that it would say that we need to increase our knowledge on the idiopathic cases, just to be sure what the gamete quality and genetic background.
Idiopathic means that we don't really know what it is.
We do not know exactly. So
good point.
I think that I'm just looking whether we have any other questions. No. So Marcos, I think that we should close this session, and I would like just to thank you, the ISA and the EFFS, for organizing these meetings, webinars. So please, Marcos.
Thank you very
last
much.
words.
I'd like to say again, thank you to all the speakers for fantastic presentations. This was a very exciting session. I just want to remind everybody that IFFS will have this archived in the website always to view the presentations. So thank you, Giampiero, Edgar, and Antti for being live here with us. And we look forward to your next session in next month. So you will receive information, and thank you very much, everybody, for your attendance and your interesting questions.
Thank you.
A pleasure being here. Thank you.
See you also in Washington.
Yes.
Bye-bye.
Bye-bye.
Bye. Thank you.
Thank you
Thank you
all.
to all the audiences. Thank you.
Bye.
Bye-bye.